hope, who have joined our this eNeo course, which was conceived by our Dr. Pankaj Garg, President-elect of IAP Delhi and a very senior renowned neonatologist at Gangaram Hospital. And Dr. Ravi Sachan is a neonatologist at GTB Hospital. And we have selected a very niche state of senior and eminent faculties for this 15 session series. And today's our guest speaker, Dr. Surender BISHT, is a renowned personality, which I'll leave Dr. Pankaj Garg to introduce. Yeah, Dr. Sanjeev is our guest chairperson today, this morning session. He is a renowned personality from Aligarh and an executive board member from in Central IAP from Uttar Pradesh. Welcome, Sanjeev ji. And Dr. Ajay, please, आप बोलें.
Thank you, sir. I request Dr. Pankaj Garg to say a few words for today's session.
Thank you so much. I think this program is based for office-based pediatricians to upgrade their knowledge. So we have included topics which are not very core neonatology, but something which needs to be done by each and every one of us. So as I always say, it's a responsibility of not only neonatologists, pediatricians, medical officers, and nurses of the country to take care of the newborns of the country. There are 24 crore, 2.4 crore newborns are born every year. So we have to collectively take care of them. And incidentally, today is our Nurses Day, is also International Nurses Day, is also being celebrated today. So it is important to remember the need of nurses into the field of neonatology. I'll request Dr. Sanjeev Kumar, CIP EB member from Aligarh, to say a few words on the need of NRP in the country, and then we hand over to Dr. Surender. Dr. Sanjeev, please.
Thank you, Dr. Pankaj. Thank you, Dr. Alok. A very nicely conceived program. It's a need of the hour, because all the working pediatricians, they need this type of refreshment and this type of updating of knowledge. So it's a very nicely conceived program. And we have got NRP today, and none other than Dr. Surender BISHT is our speaker. He's HOD Pediatrics from Swami Dayanand Hospital, Delhi. He's been the Secretary General National Neonatology Forum in 23-24. He was the NNF National Treasurer 21-22, NNF National Executive Board Member 2019-2020. He is the National Convener carrying both ends of the cord IAP FOXY Perinatal Module. He is the WHO CRO Member Trainer, Quality Improvement, Technical Advisor to Nationwide Quality of Care Network, National Mentor, Lakshya, Ministry of Health and Family Welfare and NQOCM. And he's a very, very well-known neonatologist in India. So I welcome Dr. Surender BISHT for his talk today.
Thank you, sir. Thank you, Dr. BISHT, to please start sharing his screen and start the presentation.
My screen is visible.
The queries in the question answer box.
Yeah.
My screen is visible.
Yeah, it is visible, Dr. Surender.
Thank you, Dr. Sanjeev, for this kind introduction. Thank you, Dr. Alok Bhandari, Dr. Pankaj Garg, for conceptualizing and running and effectively roping in young pediatricians and you can say neonatologists who are involved in care of newborns for this program, very important program, which is, as I get to know, that has become quite a rage, quite a important program for certificate course for many of these. Thank you, Dr. Ajay, who is the coordinator today, and I'm really thankful, Dr. Ajay, for starting it in time. As far as neonatal resuscitation programs are concerned, and thankfully IAP and NF both are doing it for so many years. Let me just go through the history, which is not there in the slide certainly. India has the ignominy, or you can say the bad name, of having the highest number of newborn deaths in the world right now. Every fourth newborn who dies in the world is an Indian. So there's no pride in that, certainly. but that can be because of the sheer number of births we have, as Dr. Pankaj has rightly said. We produce born Australia every year, 2.4 crore or so every year. And imagining that some percentage of per thousand deaths, newborn neonatal mortality is still hovering around 25, 20 or so per thousand. So imagine those in lakhs and lakhs of babies are dying every year. And every day there are deaths occurring across India, more so in states which are lagging behind the target which the government of India or the WHO has set for every nation under the every newborn action plan by WHO and India newborn action plan, which was adopted by India in 2014, so that India will have a single digit NMR, neonatal mortality rate, which means a mortality rate of less than 10 per thousand, which we need to achieve. And for that, the dividends of this program should and would come if we are able to save babies. And the babies are dying. 70% or 75% of the babies are dying around birth. So that is a time when you require, or around in the first week of life, something that babies are dying. And the major causes which used to remain earlier were, the first most cause was earlier was asphyxia. Now it is the second or third most important cause, depending on the number of preterm babies which are being born in different parts of country. Still, in states with highest mortality, asphyxia counts. It really counts. And how are we going to reduce that incidence? We are going to provide people who can feel confident, who are available, able to provide some care to newborns around birth. So with this background, so I'm just trying to, I cannot teach you neonatal resuscitation program across in this 1 hour, but I'm trying to tell you what happened and how the program changed. So from conceptual based, from expert opinion based program, how the neonatal resuscitation program is one of the most stringent evidence-based program of resuscitation available in country or in anywhere in the world. NNF has its obligation as part, because we are the National Neonatology Forum, and neonatal resuscitation program, newborn resuscitation program is a core fundamental program which our forefathers, our grandmasters started way back in 1989 or so, when Dr. Vidyasagar came from US and trained some bunch of young neonatologists of those times, which included Dr. V.K. Paul, Dr. Meherban Singh. Those people were young, Dr. Faridi and all. And these were the people then they took, Dr. Devrari and all, and these were the people then they took the program of NRP to different parts of country. Dr. Panna Chaudhary of IIP, the president of IIP of in 2009, started this IIP NRP FGen program, which brought down the reach to the furthest point, to the districts, to the cities, to the PHCs, and that actually improved the skills of newborn healthcare providers. So NNF is organizing, has organized on 7th of April in NNF Delhi, led by Dr. Mumtaz Jarju and Dr. Naveen Gupta, has organized one advanced NRP provider course in Chacha Nehru on 7th of April, and the second is likely to happen next week, next Sunday, in Rainbow Madhukar Hospital, Saket. So all of you who are registered, please join. And similarly, across the India, all states are conducting these NRP provider courses, and all healthcare providers who are available at the time of delivery, whether it be a nurse or a doctor, should be able to handle confidently babies in this skill. So the survival will depend on the golden hour management of the newborn, and that first hour, as you say, about any emergencies, is so critical in having a good outcome. So with this today I'll be just talking about the neonatal resuscitation program which is about antenatal counseling, team brief, how are we going to do it, and providing support to respiratory system, giving support to cardiovascular system and all. And this is something which, these are the programs which are there in the NRP. Similarly, we have something to prevent hypothermia. Let me just use my pointer. I hope you are able to see my pointer. You're able to see my pointer. So that hypothermia.
अपने उसी को पॉइंटर यूज कर लो लैपटॉप का.
हाँ नहीं मैं पॉइंटर को ही देख रहा हूँ. हाँ मुझे उसी को कर रहा हूँ. आजकल वो नहीं आता, लेजर वाला नहीं आता है. Something like that. So this is the hypothermia which I'll try to deal. Therapeutic hypothermia I'm not talking today. Delayed cord clamping certainly I will touch, and infection is certainly a different part, and obviously what investigation needs to be sent in the first hour, it's something which I'm not going to deal today as part of NRP. So what happened over the years? There were changes in algorithm. So, and that is why all pediatricians of your years and years who were trained earlier in 80s or 90s or 2000s or 2010 also need to update their NRP skills. And the key components of the new NRP was behavioral skills, communication skills, how to make a good team, how to provide counseling to families antenatally. The other things which came since 2015 also were delayed cord clamping, skin-to-skin care, hypothermia prevention. How the ways of stimulation have changed certainly. The suction, whether it should be done, not done, meconium state delivery, all those things would be discussed. Positive pressure ventilation, yes. How to make up effective seal, how to check that effectiveness, and what are the devices which are now available over the time, from having a flow inflating bag to a self-inflating bag availability, and then coming to I was told by somebody of that time that in 80s mouth-to-mouth resuscitation of newborn was being done in Delhi itself, and the trained birth attendants, the DIs were told how to do mouth-to-mouth resuscitation of newborn as well. So that was a time we have moved from those years to this year. We are having high and TP resuscitators availability in labor rooms, in not only in private sector but in so many government hospitals now. Intubation, what are the size, depth of length of insertion, tip to lip distance measurement, how you're going to do it, and what are the drugs and the ways to do chest compression. So if you look at this algorithm, I'm trying to show you the three algorithms, which is 2005, 2010, 2015, and 2020 will come. And we have made our own NRP, IAP, NNF, NRP algorithm by consensus guidelines of the group comprising of people both from Indian Academy of Pediatrics and National Neonatology Forum, a joint great collaboration. So in 2005, so people, I don't know whether there are people who are still who were trained at those periods. So there were 5 questions. So if you're one of your teacher, still for the young student, because for my residents who are coming from different parts of country and coming to work in Delhi as a junior resident or senior resident, they tell us that some of the people still are following their own practices, and likely so, because if they're not got retrained or they have not de-learned. So obviously, and there was nothing bad in actually those questions, but yes, the time has changed. We need to move from those. Initially, there were 5 questions where the color was also noted, and there was a timeline which continued for every 30 seconds, 30 seconds, 30 seconds, 30 seconds kind of thing. So when we got trained in 95, and I joined my post-graduation in UCMS in Delhi. So I was, this was the algorithm, 30, 30, 30, and that because Dr. Faridi was a trained NRP trainer. And so UCMS had a very active NRP program going on. Every intern were getting trained in that with the mannequin available, good mannequin available at that time also. So color was pink, and we had this timeline of 30 seconds. And this meconium and color pink were there. And we had 3 levels of care: routine care, supportive care, and ongoing care. And then came 2010 guidelines, where PPV was supposed to be started, should have been starting and doing PPV finishing by 30 seconds or so. So they were trying to add both the initial steps and the positive pressure ventilation in the first 60 seconds, which was more so the 2005, 30 seconds of initial steps and 30 seconds of PPV. This was what was kind of said, but there was a gray line. You can pass that line of 60 seconds, 30 seconds and 60 seconds. So still, but it was felt that within 30 seconds, initial step will be done. So which is not so, and which is not seen in studies, because it was found that the usual time taken, if somebody is doing an effective initial steps properly, doing a proper suction, kind of a proper effective drying, it would take around 50-55 seconds or so, and it will be only by 1 minute or so that then a decision or evaluation about starting positive pressure ventilation can be made. So the algorithm which came in 2015 by published in Circulation actually said by 1 minute, you have to take a decision of starting positive pressure ventilation. And obviously, drying was an initial thing. And as you saw, you can see here, the questions decreased from 5 to 3. Term gestation, breathing or crying, and good tone. And I'll come to our guidelines, which were there around that time. So India never subscribed to these 3-5 questions because it is very difficult to assess tone. And there's too much subjectivity. Some may say this is not a very, the tone is not good, whereas somebody may say it's a bigger baby. So it's subjective, it's not measurable. And the other thing was term gestation. In India, with the EDD, the estimated date of delivery, not very clearly known to people. LOP is not very clearly known to people, and there was non-availability of first trimester ultrasound. The gestation cannot be accurately predicted just by looking at the baby at birth also. So, and you're not going to do a new Ballard score immediately at birth. So it would be just again an assumption that baby looks preterm or term. So in India, we always had only one question, which was breathing and crying. I'll come to that. And then drying came here in 2015. Then obviously drying was kind of taken, given precedence over other things, because hypothermia became a major element in improving or not having difference in outcomes of babies who were resuscitated. Yeah, and these were the steps who will go to post-resuscitation care, and from there, how we are going to do corrective ventilation, corrective steps. And this, when are you going to consider intubation? Where it was earlier, there were asterisks when you need to you can do intubation. Now you are considering intubation even when the heart rate is below 60 or so, or you need to do chest compression, or during ventilation corrective steps also, you can do intubation. This was the NR India, which I'm saying, which I was talking this, versus NRP. This, we always had only one question, which was breathing and crying. And I gave you the rationale, which was more scientific. It's not that we were resource limited setting. That's you assess the tone very effectively. There's no way you can correctly tell the gestation. So India was. You're able to hear me?
Yes, Dr. Bisht, you are audible.
Yeah, no, because it was showing my internet connection is unstable. So I think
no, you're visible.
So so our questions remain that, and something which we did very nicely was we did something like this heart rate after 5 inflation less than 100 beats. So this was our initial. We did this in way back in early 2000s or so, 2010 or so, and this was what the ILCOR, International Liaison Committee on Resuscitation, agreed later, now, some years later in 2015 or so, that this kind of assessment needs to be made. You cannot continue for 30 seconds without having a good assessment of this, or you cannot just change over and do corrective steps immediately after the first breath only, just because the chest rise was not there or the heart rate was not there. So India had this concept of giving some inflation because to all the students who are there. So what happens when you're trying to do positive pressure ventilation? You are doing it, and what happens? I see so many of the residents or the nurses, they would see, and if they are not able to see a chest rise, they would change it. They will start doing some corrective steps. But it has been seen in studies that it takes few breaths, stacking of few breaths, so that the alveoli gets inflated and the lungs get inflated, and then only you can have a visible chest rise. Changing, though there was air, there was air going into the lungs and alveoli, but there was no visible chest rise initially because it was the lung capacity was not to that extent. The lungs were not inflated to that extent to see a visible chest rise. But there was air going and there was some air exchange happening, and that even little bit of air which was going and could actually help in improving the heart rate, improving the oxygenation. So rather than abandoning that event at that point of time and then jumping to do corrective steps would hamper and delay the air exchange and delay oxygen, improvement in heart rate in the babies. So India had that concept much earlier, though it was just by expert opinion and things. But India had that, and we continue to follow that in our NNF and our India guidelines. And now this heart rate was 5, and what was the change here? By 2015 and then 20 also, the international guidelines did not. They felt observational care is not required. They had only 2 levels of care. Any baby who was kind of depressed required even initial steps, and some degree of PPV would go for post-resuscitation care, meaning that they would be admitted in an ICU. And in India, imagining that some 10% of the babies require resuscitation at birth, and out of those, around of those 10%, 60-70% some would require some just initial steps or some minor PPV only, positive pressure ventilation. So for 30 seconds or 15 seconds or some seconds of this. So keeping all those babies, 10% of 2.4 crore, 24 lakhs. Yeah, 24 lakhs. And those 24 lakhs of those, if 60% are coming, so imagine how many NICUs would be required to keep. And it has been found that these are the babies who otherwise can start breastfeeding very early and can be managed by mother side only. So India had this concept of, because of challenges, and more so because of with family integrated care, babies being taken care by mother better than in a NICU. This was considered that observation care would be provided, where mother would be observing baby along with a healthcare worker who would be around and looking after the baby. The NRP 7th edition, now coming to 2015, and before that, the scheme of training was going like this: foundation of neutral resuscitation, preparing for resuscitation, preparing initial steps, positive pressure ventilation, and then chest compression, and then alternative intubation, and then medication. So by 2015, it was realized that if somebody is requiring chest compression, it is prudent to intubate to the baby beforehand only, and so alternative airway. And even when you have done all corrective steps, your last for MR SOPA, the A is alternative airway, you would require intubation. So considering that the heart rate not improving by 30 seconds of effective PPV, maybe because of still not very effective ventilation, you would like to intubate that baby and then go for 30 seconds of positive pressure ventilation. And after that, if your baby is still not having increase in heart rate and the heart rate remains below 60 per minute, then you would go for chest compression when you have already intubated the baby. So this was the change, and obviously preparation for resuscitation was given some highlight and post-resuscitation care required. And there was a new section in each lesson, which I'm going to elaborate, because that is what makes NRP more effective. I'll just come to that. And this is our IIP NNF NRP 2022 guidelines. And so this is what India will follow as per Indian Academy of Pediatrics and NNF joint MOU in 2020. This was there was a book which was produced, and this is a book, a textbook which you can purchase from Amazon at some cost, and that is a book which will be available for NRP provider courses. So you can have that book yourself, or you can get it while you are doing a training program. So there we are still following the 3 level of post-resuscitation care, or you can say the care after resuscitation was routine care, observational care, and post-resuscitation care. So in this algorithm, you do some parental risk assessment, parents are counseling, there is a team briefing and equipment check, which goes on in preparation. So there are these 3 things which are important for preparation. And then at birth, we do assess only, we note the time, and we place the babies on mother's abdomen. So it is now emphasized that all babies will be put on mother's abdomen. And I believe that the time has come when most of the babies, 80–90% of the babies are now put on mother's abdomen, because the obstetricians have learned this. Okay, so it is, this is what IAP and FOXY, when I was a part of that convener for the parental committee, it was then I realized that FOXY had adopted it, and FOXY is now putting all babies on mother's abdomen at birth, and they're doing drying and assessing for breathing and crying. So this is how it goes here. And if the baby is breathing, you are going for routine care, which entails no suctioning. Do not touch the baby if there are not enough secretions. Only dry. Drying means drying from head first, because that is the area which has the largest surface area and likely to cause hypothermia, because it is still wet because of evaporative losses. So you need to do drying of head, the chest or the back, just faster. Go like this: 1, 2, 3, and 4. This is how. So by 4–5 seconds, you should be able to do one quick drying. Not that you're going to clean and dry each and every folds of the baby, not or from the ear pinna you're trying to remove some drop of water. That is not important. You need to do a faster drying, because you have to assess that. And secretions are only clean, whether you clean it with a gauze piece or you have a bulb syringe, which is not preferred that way. So that you can do. And delayed cord clapping, which I will elucidate or allude to at a greater length later. So this is what is required for routine care. I mean, we will do some ongoing evaluation also. If the baby is not breathing, crying, obviously we are going to go for some initial steps. I'm talking to you, taking you through the NRP once, because I'm not going to talk about each and everything later. So you cut cord, place on the radiant warmer, position airway, stimulate, clear secretions if needed. So these are the 5 initial steps which you do, apart from drying, which was already done. You are providing warmth. Positioning means just extending the head a little bit, or you can say keeping the baby in a sniff position so that the head is not flexed and the airways are patent. So that sniffing position is required. Sometimes you need a shoulder roll. If there's a large capet, probably you would require a shoulder roll to do that extension of the head. And stimulation, obviously you need to do some firm stimulation. It cannot be just to flick on the sole. Flicking on sole is gone, because you need to do some firm stimulation. But firm doesn't mean you have to slap the child or beat the child or put the baby upside down and try to stroke the chest. You are not going to do so. So it has to be some firm stimulations on baby's back, 1, 2, maximum 3 times. So again, this should not take more than 3-4 seconds, and you need to make an assessment immediately after that. And that is whether the baby is apneic or gasping, or if the heart rate is less than 100 per minute. So to know that heart rate, of less than 100, while initial steps were being done, so one of your helper would
We lost connection, Dr. Surender, appears. I think Dr. Surender has lost connection. Just wait a minute. He should be joining soon. Dr. Surender, you're back. That's fine. Huh?
So I know I live in very close to Delhi. So being in NCR and still not getting a very stable.
I think technological glitches are part and parcel of life.
Yeah.
Don't worry.
So
Restart. But we lost you just a minute back. Not a problem. Huh?
Yeah. So I was here. Yeah.
Yeah, that's fine. Huh?
That's what Yeah. Excuse me for this the break. Maybe it was required also.
No problem. Go ahead.
Some break is always required. Yeah. So ये कहाँ के हैं वैसे Dr. Pankaj? Participants, they are from.
Participants are all across India, but they're mainly from NCR.
NCR, yeah.
NCR are northern states, but they're all across.
हाँ, तो मेरी आदत थोड़ी हिंदी बोलने की है और.
No problem. I think most of it's fine, but maybe.
No, it's fine. मातृभाषा का थोड़ा प्रयोग मैं करता हूँ और
no problem.
थोड़ा ज्यादा बेहतर लगता है उसमें, क्योंकि मेरे को लगता है कि जो संवाद है वो बेहतर हो पा रहा है और लोगों की समझ पे ज्यादा जा पा रहे हैं। तो जहां तक सवाल है कि आपका पीपीवी तक आप पहुंच रहे हैं, आपने असेस कैसे करा कि किसको चाहिए, who would require positive pressure ventilation. That is an effective way. Sometimes people delay that. So for all those who are, so because we are afraid and we are not confident. Now I'm telling you something which is beyond the training. People are not confident of able to do PPV or chest compression, and they fear that if they do this and somebody says you could not do effectively, they want baby to revive on its own. So they keep stimulating the baby. They do keep doing suctions, and this is what I see with many of the resident doctors or the young people, because they are not confident they will be able to do effective positive pressure ventilation. On the contrary, there are people who will jump to do positive pressure ventilation without doing the initial steps and waiting for baby to revive. So you need to strike a balance between, and that is what is given here, the right time to make a conscious decision Now this is, well, 1 minute has passed, baby is still not breathing. This is the time when I have to provide positive pressure ventilation, and I'll deal with positive pressure ventilation how to do later. But then you give it for some time, and by that time, now Indian Academy of Pediatrics and NF now have said that there should be a SpO2 monitor with COVID pulse oximeter being available across country just within a month or so. It is not an issue that all our labor rooms will have and should have a pulse oximeter, and by providing those pulse oximeters, people can assess the heart rate and obviously need for oxygen later whenever it is required, or titration of oxygen whenever it is required. So you have to provide that for 30 seconds. And how do you do that? I'll tell later. And then after 30 seconds of effective PPV, and that 30 seconds of effective PPV will be told later. Heart rate of less than, if still the heart rate is less than 100, apnea gasping, and you have checked that the chest movement was adequate by actually undergoing the, by doing the corrective steps, or then as said, by putting up an alternative airway, then you will go for a heart rate, do an assessment after 30 seconds of growth, and still if the heart rate is less than 60, you would now go for chest compression coordinated with positive pressure ventilation after intubation and providing 100% oxygen. By the time ECG monitoring is desirable, and people are asked to prepare for UVC insertion, because this baby may require medication, because after 1 minute of chest compression, you are required to give medication, whether intratracheal or IV, both, because intratracheal is not counted. So you have to prepare for intravenous, which is through umbilical vein only route, and so you would require. And there is a target preductal saturation, which is now mandatory to in that sense here, and this is for babies term, because the studies and the data was for term babies. Preterm targets may come in coming years. As of now, the target preductal saturation are for term babies, and we need to follow this for titrating oxygen, oxygen concentration being provided to babies. So increased emphasis has now been on teamwork and preparation before resuscitation. So having a structured checklist certainly helps, and you need to document what is required. You need to have some roles and responsibilities being assigned beforehand, and to all the budding neonatologists and pediatricians. What is more important is, and which is an NF mandatory criteria for accreditation, is to have a check algorithm pasted there, have a checklist pasted there in the labor room at the delivery point. So while you are assigning role to your team, it is a very good idea to go through that algorithm like this. You said this is okay, if the baby goes like this, I'll do this. It will kind of a revision of that algorithm, the algorithm which I just showed you. You must paste that in your labor room, and then before every delivery, please go through the algorithm. And before every delivery, if you have your helpers, your nurses and technicians who are available there and who will be providing help, you just go through. When I do this, you please be ready with this. When I do this, you please be ready with this, and you do this. So that is how it's going to go. And for this, some behavioral skills are required. These 10 behavioral skills are the key to have an effective neonatal resuscitation as a team. So what are these? You need to know your environment. That for preparation, you need to check equipment. You cannot say, oh, my equipment was not working because the nurse in the last duty did not take care of it. You are responsible for the baby who was going to born, and you were available 10 or 15 minutes before that, before the birth, and that is good enough time when you could have arranged or seen that the functional status of the machines, the ambu bag, the availability of oxygen, the availability of laryngoscope, the availability of extra batteries, bulbs, all that, suction pressure being regulated to 80 to 100 millimeter, all that being checked beforehand. So that is, you should know your environment. You cannot just say, I am a senior, I'm a pediatrician, or I'm a doctor, I'll just come and do the touching of like this. You are not supposed to do this. You need to oversee it yourself. You need to supervise that also. And you should know the location of the resuscitation equipment. You should know how to call help. You have already talked to families, and you have available information about the mother, the baby, the fetal investigation. What was the RH status? What was the blood pressure of the mother? What was the blood sugar of the mother? What is there the risk of hypothyroidism, cord prolapse, cord events? Everything needs to be known beforehand, and you need to anticipate and plan accordingly. And while planning, you need to assign roles and responsibilities, and that is what is known as anticipation and planning. And then you assume a team yourself as a team leader, and there are attributes of an effective or a good team leader, like he needs to articulate its goals clearly, that look, this baby looks like this, and if we need to do intubation, you will do this and I will do this, and if we need to do chest compression, you kindly prepare medication by the time we are doing chest compression. So this is something, those kind of roles the team leader needs to articulate beforehand clearly, and doesn't assume that people will on their own start doing things. Okay. And you have to think out loud when you are looking at your chest is not rising with possibility. Oh, I think is the chest rising? Chest is not rising. Should I do corrective steps? Think it loudly, speak it loudly. So whatever you're thinking, you should do it loudly so that the other person can hear. And you cannot assume that people were looking at you, watching at you, and they should have known that all. That kind of situational awareness is something which needs to be maintained by the team together, and that is maintaining situational awareness together. And this is in case you need to hand over leadership to another, it will be done. So that communicate effectively means some closed loop communication needs to be done. You need to know your team members by name, and inform your teams, order medications, by correct dose, name, route correctly, and then check it whether they have understood or not. And concise, clear language. Don't be very fast, not very slow, and verify information and check it that whether you have understood, and then the person is saying, okay, I'm loading 0.6 ml of 1:10,000 injection adrenaline in a 1 ml syringe. And say, okay, that is how you do it. I'm pushing a flush of 3 ml normal saline. Okay, so this is how you're going to do it, and you are going to delegate that workload optimally. And somebody as a leader, you need to see not only what you are doing, you need to have your attention wisely on all other people, what are they doing. And
I think we have seemed to have lost Dr. Surender BISHT connection again. So just wait a minute. Let him log in again.
hello, I'm back. Am I back again?
No problem, Dr. Surender. No problem. You're back. You can start again.
And what was the slide? Which was where was I? This was the slide?
Yeah. Just a minute. Let me see. Your slide is not yet visible, huh?
Visible?
Not.
Okay, I've not shared. Sorry.
Yeah,
I've not
share.
shared. I've not shared. I will. This was the slide?
Yeah.
Another break, and I wanted to see what is the time, and I now got to know.
So this is 45 minutes. So maybe 15 minutes more. Dr. BISHT.
15 minutes or so. Okay, no, I'm slow then. I need to fasten up. Yeah. So बात यह है कि अब इस जमाने में अगर हम एविडेंस नहीं देख रहे हैं और हमको पता नहीं है कि क्या स्ट्रेंथ ऑफ एविडेंस है और क्वालिटी ऑफ एविडेंस क्या है, तो एज पीडियाट्रिशियन वी आर फेलिंग ड्यूटी, बिकॉज पीडियाट्रिक्स में ज्यादातर रिकमेंडेड जो भी हम चीजें कर रहे हैं, अब हमारे पास एविडेंस है ज्यादातर फॉर मोस्ट ऑफ द गाइडलाइंस we have evidence and recommendation based on that. We must follow those. And we are not saying you don't go by expert opinion, but try to put them in the last. That is the last level of evidence, level CEO, which is just by expert opinion. So you have to go by level of evidence, quality of evidence by level A, which are high quality RCTs and meta-analysis of those high quality RCTs of more than one of those. And that is something which should tell you, अगर आप उसका quote कर रहे हैं, तो I am very fine with that level of evidence. And अगर हमने उसको, then only will this NRP has given based on that level of evidence some strength of recommendation. अगर जिसका उन्होंने strong recommendation दिया है NRP में, तो please, when you are going through the book, IAP and NF NRP books, we have given those level of strength of recommendation. If we have said strong, that is, yes, it is beneficial. If we have said class 2A moderate, yes, this is it is reasonable, can be used. But when we are going towards this class 3, no benefit, you will be trying it at your risk only. And if you are using class 3 harm, then certainly that is something which we don't want. This is certainly which we don't want. The class which we can cause harm. If anybody still using class 3 harm kind of recommendation in their practice is a problem, medical legal, because the recommendations are strongly against it. So, and you need to know the level of evidence. Level A is very high quality RCTs, more than one, and a meta-analysis of those. Or then level B is with RCTs, if they are less than one, or some moderate quality evidence of group of RCTs, then it is BR, level B, but RCT. Level B, non-RCT, non-randomized control trial is level B. Yes, there's a moderate quality of evidence, still can be used, and based on that, we can give you some strength of recommendation. And level C is low quality evidence, and level CLEO is only by expert opinion, based on clinical. हम मेरे boss करते थे, मेरे teacher करते थे. Yesterday only some of my resident was just telling me, कि सर हम इसको ये drug दे देते हैं, मैंने पिछली बार दिया था and it was patient is happy. This is an anecdotal experience. This is not a recommendation. Your one experience doesn't count at all in the scheme of things. Okay, so this is what people in over years tend to do this. If you have this experience, try to correlate this with the available evidence in this. Don't go by just your gut feeling or your experience. I'll just fast. Yeah, delayed cord clamping. Yes. So why do we do that delayed cord clamping? पहले ऐसे कभी नहीं होता था. जब काटते थे, फट से निकालते थे, बच्चे तो बच ही जाते थे. क्या दिक्कत है? What is the problem? Okay. So why are we doing it? So first and foremost, no animal needs a nurse or a doctor at their birth who cuts the cord immediately. So there, the placenta comes out on its own, and then there is something, then how it gets separated or shriveled over time, it happens. Okay, or somebody eats it, something like that, it's happened. We are also mammalians. We are also having our kids coming out from our uterus or vagina. And these are babies where naturally cord pulsation should go away, then only baby should be separated from mother, because there is some extra blood is going. So if you are looking at this, if you are clamping over here, look at this. This is the umbilical arterial blood flow which is going. If you're able to see my pointer, I don't know with the color, it's yellow now. And then the umbilical venous flow, which after clamping will certainly stop. And mind you, umbilical venous blood brings blood from placenta to the fetus, and immediately after birth to the baby as well. So it gets stopped when you clamp it, but the arterial blood flow is still going on. So baby is pushing some blood to the placenta, though the baby's blood is going to placenta is not actually giving any blood to the fetus. So, and this will lead to a decrease in blood pressure over time. And what happens is there's a compression of umbilical vein, which an interruption of the flow to the fetus. There's loss of the umbilical venous return, leading to reduced left ventricular preload. There won't be any venous return. There won't be any left ventricular preload. So what is the cardiac output going to be? So the cardiac output will be lesser. And the cardiac output is lesser. Blood supply to the vital organs like the brain, heart, lungs, kidneys will be impaired. And that is causing to cause both coronary and cerebral hypoperfusion. And this will lead to obviously later decreased blood volume and hypovolemic shock also. And the placental blood volume will obviously increase because blood is actually going from umbilical or from the fetus to the placenta, vice versa. So delayed cord clamping as such, it's not delayed, it's actually natural cord clamping. So, just to say that we are causing a delay, which has a negative connotation because people feel that you are delaying something which was rightfully required for a baby. So I think this should have been some name, something differently, and some name has come. I forgot that, but it is certainly should not be DCC because it gives a negative connotation. You are not trying to do something immediately which is required for a baby. So delayed cord clamping for 30-16 for most vigorous term and preterm babies, they placed skin to skin. We are not doing it if the placental circulation is already disrupted by cause of abruptio, bleeding vesa previa, or cord avulsion. And obviously, if the baby is not vigorous, there is not very great evidence whether you should do DCC or not. There is some evidence, there is not evidence, but when there are multiple births. So physiological cord clamping and early cord clamping. So I think it should have been not DCC, it should be physiological cord clamping after ventilation. So in babies who have started breathing also. So, or they are requiring positive pressure ventilation. If you look at the two cartoons over here, you look this baby where the cord has not been clamped and versus a baby where cord has been clamped. So in this baby, the umbilical vein is actually bringing some venous return to the left side of the heart, adding to the left ventricular preload. And since the lungs are now open by providing the ventilation, and you are providing some positive pressure ventilation, there is some oxygenation, and this oxygenation would lead to decrease in vasoconstriction in the pulmonary, vasodilatation, because oxygen is a vasodilator, and that will decrease the pulmonary vascular resistance. That will actually lead to some blood going from the heart to right side of the heart to the lung, and then adding up to the venous return. So you have a venous return coming from the ventilated lung by providing effective ventilation, and also from the placenta. So this is 1 + 1 11 now. ठीक है, तो 1 और 1 11 हो रहा है आपका यहाँ पे, आपका placenta से लगातार. अगर आप, this is a situation where you are doing DCC along with positive pressure ventilation. So यहाँ पे आप दोनों कर रहे हैं, आपको एक्स्ट्रा नहीं देना पड़ रहा है, और दोनों तरफ से ब्लड जब लेफ्ट वेंट्रिकल में आएगा तो cardiac output is going to improve because your left ventricular preload has improved, and that is actually providing a stable blood flow to the brain and coronary as well, right? And obviously then it's going to the placenta as well. While you're clamping it, and there is a lung which is not well recruited, it is not going to cause decrease in pulmonary vascular resistance, and that increased pulmonary vascular resistance is actually causing shunting of blood going away from the lungs to the other circulate back to the heart. So that will certainly lead to low pulmonary venous return, and then obviously decreased cardiac output, left ventricular output, and then decreased blood supply to the vital organs. So it has changed. Earlier it was for minimum for 30 seconds. Now we are saying for more than 1 minute, and India R is for 1 to 3 minutes. And personally speaking, as long as it is okay for family and mothers and the obstetrician at that point. जहाँ पे 1-2 डिलीवरी हो रही है पूरे दिन में, वहाँ क्या दिक्कत है? बाद 2-3 घंटे में एक डिलीवरी हो रही है. What is the problem? What is the hurry? Where do you have to run that baby? Because you are actually trying to provide 30 ml per kg of extra blood to that baby. So what is the problem? It actually आपको कोई बाद में वॉल्यूम लोड नहीं देने पड़ेंगे, बोलसेस नहीं देने पड़ेंगे, ब्लड प्रेशर अच्छा मेंटेन करेगा, रेज आपका आईवीएच होने के चांसेस कम हो जाएंगे. I'll come to that also. ठीक है. So when you are doing early clamping, 30% of the fetoplacental blood volume is discarded in the placenta, 30 ml per kg also, and this causes decreased RBC volume and oxygen carrying capacity also. So a baby who is requiring ventilation and the oxygen carrying capacity is reduced because the blood is lesser. So obviously there will be increases of PPHN and hypoxic respiratory failure, and that will add up to the oxidative stress. Whereas obviously there will be a decreased left ventricular preload, which will lead to cerebral hypoperfusion, and this need for resuscitation will prolong, and there will be increased ischemia reperfusion injuries. And while this cartoon shows a very stable perfusion pressures the same way, because there is a ventilated lung and there is something like that. So the benefits of delayed cord clamping for the benefit of all, on providing improved neurodevelopmental outcomes, decreased fluctuation in afterload on and in carotid artery, smoother transition, decreased pulmonary vascular resistance, decrease in mortality if respirations start before clamping, and decreased flow from IVC on inhalation, and there is stem cell migration from placenta to baby. For preterm babies less than 28 weeks, no milking is required because that causes increase in high surge of blood into the low resistance cerebral circulation, and that may cause rupture of the juvenile matrix capillaries, which doesn't have that much of support in a preterm babies, and fragile blood vessels, and then likely to develop severe IVH. And still the lungs are still not well recruited, and this will not going to help in that cases, maybe. So no cord milking for babies less than 28 weeks. So I'm just going fast. These are the level of recommendations. So BR, that's a good recommendation, where reasonable to delay, and even in preterm babies, you need to. So this is BR level. B is a good with RCTs. Level C with low evidence still can be used, but you can do this. Expert opinion for who require resuscitation, whether you can do or not do, is still an expert opinion. So personally speaking, I would urge people to do so, but it's still the jury is not out. And for this, how are they doing? During resuscitation, you would require some area to warm because that is required. So a warmer is required. So a table is pushed in. So this kind of tables have been made where there is a blender, TPC resuscitator, a monitor, there is a warmer, and all this oxygen cylinder and a blender. All this is available, and then this is something which happens when the mother is getting delivered. Immediately you push this baby warmer into the labor room over the abdomen of the mother, so that the baby is being resuscitated not on mother's abdomen but on a trolley which is there, so that the baby is having a flat surface on which you can do chest compression and all that, where you positive pressure delay at least you can require that kind of thing. And this is the Concord bed which is there, so you can use this kind of thing where you can see a TP resuscitator, blender, a machine monitor, and all these are there. Yeah. And this is an Indian version where we're doing on near the table, bringing the things near the mother only. Other thing is about temperature, which I think now 2015 they said, because every degree decrease in the temperature of the baby during resuscitation, every degree with every minute, the mortality rises to many percentages, 28% or so, so many folds. So this was important, and this was added up. This was the new thing which was added there, and the admission temperature good. Though there was non-randomized trial, the level of evidence was this, but the class of recommendation is one. Strong recommendations means this has to be done. You have to maintain that temperature, and 2A is again a recommendation which should be done. So obviously needs prevention of hypothermia. Hypothermia also should be prevented. Yeah. So there is skin to skin you must do. This is good 2A recommendation based on level of evidence, the randomized control trial, and low quality evidence on non-randomized trial also. So all resuscitation procedures including, आप जब resuscitation कर रहे हैं तब भी आपको warm and humidified gas देने चाहिए. Temperature तो आप ऊपर से maintain कर ही रहे हैं, but आपको सब कुछ जो है ये warm area में, और सारा जो resuscitation procedures हो भी रहे हैं वो भी सारे के सारे temperature controlling interventions में होने चाहिए. रेडिएंट वार्मर आपको यूज करने चाहिए, एक्सोथर्मिक मैट्रिक्स करनी चाहिए, और वार्मिंग बंडल आपको इस्तेमाल करनी चाहिए. Yeah, this is again a good thing which meconium aspiration. Luckily, Dr. Pankaj and Dr. Ajay, अब जो बच्चे आ रहे हैं 2010 के बाद के ज्यादातर बच्चे हैं जिन्होंने MBBS भी बाद में किया है, उनको मेकोनियम स्टेन के बारे में पता है. अब कोई मेकोनियम में इंट्यूबेशन और सक्शन नहीं करता है. आई होप दैट मैसेज हैज गॉन टू ऑल एंड सन्ड्री. एंड पहले जो आप देखेंगे यहाँ पे, मैं एक हिस्टोरिकल, एक बुढ़े लोगों की तरह बता रहा हूँ कि एमनियो इन्फ्यूजन करा जाता था. भाई मेकोनियम स्टेन लाइकर है, एमनियोटिक फ्लूइड पे डाल दो, डोमोक्साइन डाल दो. आई डोंट नो डॉक्टर पंकज के टाइम पे ऐसा भी होता होगा. डॉक्टर पंकज उससे सिर्फ 1-2 साल ही पढ़े हैं. और एंड देन वी वर डूइंग कि भैया अभी हेड निकलेगा, हेड निकलने पे आप सक्शन कर देंगे, और हेड निकलने के बाद जैसे होगा आप ट्रिकल सक्शन करेंगे. पहले तो हम सभी का करते थे. देन बाय 2000 और सो इट केम कि नहीं, सिर्फ विगरस का नहीं करेंगे, नॉन विगरस का ही करेंगे. एंड बाय 2015 वी हैव सेड नो, we will not do, and there was evidence on this, and this was a landmark study from JIPMER which actually paved the way for the whole world, that showed जिनमें सक्शन करा है और जिनमें नहीं सक्शन करा है, the incidence of mass did not differ, the asphyxia did not differ, the mortality did not differ, even the 9-month survival and the mental development did not differ. So this was a landmark study done from JIPMER and which paved the way. And then again the study from BHU, and then the meta-analysis I think which has been done by Dr. Nagia. It shows no difference in incidence of mass, asphyxia, ventilation, complication in NICUs, neutral and 9-month survival, developmental delay, any of these. So in no situations people are going to do endotracheal intubation and suctioning just to clear the airways without having any objective evidence of obstruction of airways when you are doing ventilation corrective steps. That time you may do, because that is the time when you want to remove the obstruction. That is the only time when you can do endotracheal suction in a meconium stain like a baby, when you are not able to have that PPV even after doing all corrective steps. So clearing the airways, the level of evidence is certainly expert opinion and some low quality evidence, which has come because only one study was there, and that was also not there. PPV, I said I will tell you. So PPV, something new has come, and Dr. Pankaj is one of the authors of one of the major studies which is quoted worldwide. So Dr. Pankaj, Dr. Thakur के नाम से है वैसे वो study, but आप सब उसका part है. So जो study को हम पूरा दुनिया quote करता है, गंगाराम की वो study है जिसमें TP resuscitator इस्तेमाल करा गया था. And I'll come to that evidence later. And so always stand on the head side. I'm not saying you have to use TPs all the time, but certainly आप अगर आप पॉजिटिव प्रेशर सेल्फ इन्फ्लेटिंग बैक भी कर रहे हैं, आपको हेड साइड पे खड़ा करना है, तो 2 हैंड टेक्निक आप इस्तेमाल कर सकते हैं बैक पकड़ने के लिए, इसके लिए भी टीपीस के लिए भी. एंड मेंटेन अ सील विद 1 हैंड टेक्निक एज वेल इफ यू वांट टू डू इट. एंड देन फ्रॉम अ टॉप डाउन आपको ऊपर से पकड़ना चाहिए, बिकॉज दैट इज अ बेटर वे rather than making a seal like this. It's always better to use it like a tong, which I personally ask people to do so, and use PEEP when providing PPV. So that is the benefit of using TP resuscitator. You do a first heart rate assessment after 15 seconds of starting a PPV, and not just do MR SOPA immediately after failing in first 2 breaths, making any improvement in heart rate or any improvement in the chest rise. So you have to wait for 15 seconds and then see whether the heart rate is improving or not. If the heart rate is improving, you don't even have to see the chest rise. But if the heart rate is not improving, then you look at whether the chest is moving or not. So there may be incidences when the heart rate is not improving because of certain reasons, but the chest is moving, implying that there is a gas exchange which is occurring. And then if nothing is happening, heart rate is not increasing, chest is not moving, probably that is the time when you need to do MR SOPA and do something else. This is how you're going to do. MR SOPA, I think you know, mass readjustment. You do 2 steps, give 5 inflation, see whether the chest rise is there or not, heart rate is improving or not. You do another 2 steps, then suction, mouth and nose, and then open mouth, and then do 5 inflation and see whether it is improving or not. And then do one, increasing the pressure by giving 2 fingers, then 3 fingers, giving more finger. And if you're using a TPs, increasing the PIP by increasing the pressures in increment of 5, 10, centimeter increments, maximum 40. And then if not, then this is how you're going to go. And after 30 seconds, you need to look at the heart rate, 100, 60 to 100, and less than 100, less than 60. So this was the sustained inflation trial, which started and which was such a big thing. Now people were doing 10 seconds and 20 seconds of inflation, sustained inflation, and saying कि हमने वो करा उससे बच्चे better हो गए, especially in preterm babies. But it was found that death was more, and that this trial, big SAIL trial, was abandoned, and there's a strong recommendation now against sustained inflation. Intubation, the new thing about intubation is certainly that you don't, now you have to measure the nasal trigger length, which is from this midpoint of the nares to the triggers, and this is the tip to, this is plus 1 centimeter, which is the tip to lip distance should be inserted, and that is to be marked by everybody. You cannot just push the endotracheal tube. अब जा रहा है तो जाने दो ऐसे नहीं कर सकते, because that it will do one lung ventilation. Your all efforts are going to go waste. Just because you do not want it to slip doesn't mean you can push it into right side of the lung. Ways to note heart rate. So there are many ways. We were looking at pulse palpation, which is not an effective way of doing it. Then auscultation is still a very effective way of doing it, that you have nothing, but you need to have a very good ear, and in that hustle bustle of the labor room, whether you are able to listen to it properly and the alarms blaring. So whether it not, then you have a pulse oximeter and ECG, and now targeted echocardiography and NIRS also, near infrared spectroscopy also. So during resuscitation, obviously there's a 2B recommendation, class of recommendation based on the low quality evidence that ECG can have rapid and accurate measurements, but I'll come to that also later also. And then, so yes, because if the heart rate is not coming under and is underestimated, you may likely to do chest compression and then medication, because आप heart rate सही से सुन नहीं पाए, सही से कर नहीं पाए, हो सकता है बच्चे की heart rate ठीक हो, but आप नहीं देख पा रहे हो, नहीं कर पा रहे हो, तो unnecessarily बच्चे को chest compressions और adrenaline चल जाएगा. वैसे भी पहले के जमाने के डॉक्टर होते थे या नर्स होते थे या कहीं ऑब्सेशन, एड्रेनलिन लाओ चलता रहता था. That was the thing. So that depends so much on actually having a right heart rate, and you measure it only for 6 seconds. ECG can give you an accurate thing. It's a good expert opinion, which can do this. Chest compression, nothing much. You have to give two thumb techniques have to be used now. So all has to do by two thumb. कोई भी finger से newborn में नहीं करेगा. That is not done. Pulse की बात अलग है. I'm talking about newborn. You have to do only two thumb technique only. You have to do it and use 100% oxygen. Cardio is the thing which you have to use. You have to see whether chest rise, the lungs are getting ventilated along effectively or not. There is an alternative airway. The rate is on 90, at least 90 to 90 and 30. Total 120 events in those that time in 1 minute. And the depth is almost 1/3 of the AP diameter, and oxygen is 100%. So cardio needs to be followed in that case. The quality is, you have obviously now people were initially used to stand on the lateral side of the babies. Now the over the head OTH position is seen, and it is found that is equal whether you are doing the quality of chest compression and ventilation, and the new NRP 2020 actually preferred over the head only, so that the area is available for the one who is trying to cannulate the baby through for umbilical venous cannulation. Yeah, chest compression 100%. I will not touch this because there is a debate on whether you should use 100% oxygenation during this, and there's a LAMP study on this by Satyan. Yeah. So whether you should use the oxygen level, what is the FiO2 you should use? Room air for everybody for babies less than 35 weeks. So you can use because the critical outcome of all cause long-term mortality has showed some benefit of using some concentration, 21 to 30% of oxygen to decrease the critical long-term mortality. And while tracheal suctioning, we have already said all trials shows low certainty evidence. I'm not going to do this. This is something which has after 2020, for all the residents and the doctors who are there, ये जो NRP की evidence है, जो हम बोल रहे हैं, हम सब लोग बोल रहे हैं, और जो किताब में छपता है, it is based on International Liaison Committee on Resuscitation, ILCOR. जो सभी की रिसर्चिटेशन गाइडलाइन बनाती है, बच्चों से लेके न्यूबॉर्न से लेके बड़े एडल्ट तक की सबके बनाते हैं। उसके अंदर एक ग्रुप है जो न्यूनेटल रिसर्चिटेशन देखता है, और वो बीच बीच में अपना ये कोस्टार है आपका कमिटी ऑन साइंस ट्रीटमेंट एंड रिकमेंडेशन, जो अभी तक का एविडेंस इकट्ठा होता जा रहा है उसके सिस्टमेटिक रिव्यू करते हैं, उसको गैदर करते हैं। आज तक हर 5 साल में ये गैदर करते हैं, एंड देन दे कम अप विद सम रिकमेंडेशंस। सो अभी 2020 के बाद की जो कुछ है, मैं क्योंकि मैंने कल परसों ही जो देखी, जो ये कोस्टार रिकमेंडेशंस जो चल रही है, डिस्कशन डिबेट में चल रही है, वो मैं आपको दे रहा हूँ। एक तो डिलेड कॉर्ड क्लैंपिंग इन प्री टर्म बेबीज, टर्म बेबीज में तो करना ही करना है, सारा एविडेंस है। प्री टर्म बेबीज के अंदर डिलेड कॉर्ड करना है कि नहीं करना है, सर्वाइवल में कोई खास फर्क नहीं आया है, देयर इज नॉट मच चेंज। द माइल्ड बेनिफिट इज इन हाई हेमेटोक्रिट एंड यूज ऑफ एनोट्रोपिक मेडिकेशन एंड हाई मीन प्रेशर ही आया है अभी इन प्रीटर्म बेबी जब आप डिलेड कॉर्ड क्लैपिंग करें। डिलीवरी रूम हार्ट रेट मॉनिटरिंग किससे करनी है ड्यूरेशन ऑफ पीपीवी में, तो उन्होंने यूज करा ईसीजी वर्सेस ऑस्कल्टेशन वर्सेस पल्स ऑक्सीमीटर। और जो एविडेंस बता रहा है अभी दुनिया का 2020 के बाद का, ये जो बता रहे हैं एविडेंस, इसमें ये बता रहा है कि कितनी देर का पॉजिटिव प्रेशर वेंटिलेशन चलेगा अगर आपने ईसीजी से करा या पल्स ऑक्सीमीटर से करा, क्योंकि हार्ट रेट आप मेजर करोगे तो क्या कुछ फर्क पड़ रहा है, उसमें फर्क नहीं आया। बट हाँ, ट्रेकियल इंटुबेशन कम हो गए 25%, द रिस्क RR इज 0.75, एंड दैट मेक्स इट कि 25% आपका इंटुबेशन कम हो गया, बिकॉज यू नो कि आपका हार्ट रेट बढ़ रहा है, एंड दैट हैज लेड टू रिड्यूस इंटुबेशन। एंड ऑब्वियसली चेस्ट कंप्रेशन और मेडिकेशन पे कोई खास फर्क नहीं पड़ा है। डिवाइसेस फॉर एडमिनिस्ट्रिंग पॉजिटिव प्रेशर वेंटिलेशन, और ये टीपीस वर्सेस सेल्फ इन्फ्लेटिंग है, और ये जो स्टडीज जो बेनिफिट और हार्म वाली है, इन हाउस हॉस्पिटल मोर्टेलिटी में नहीं है, बट बीपीडी कम हुआ है। और ये डॉक्टर पंकज एंड डॉक्टर अनूप ठाकर वाली जो स्टडी है, दैट इज वन ऑफ द स्टडीज ऑफ दीज 4 ट्रायल्स विच शोड अ पॉजिटिव प्रेशर। एंड ऑब्वियसली न्यूमोथोरैक्स भी आप लोगों ने कम बताया था, जो सारी दुनिया मानती है। और उसके अलावा 3 स्टडी और ने भी यही बोला, 3 क्या 5 स्टडी हो गई हैं अब, जिसके अंदर ना अब 2000 से ज्यादा बच्चे कर लिए गए हैं। पहले जब स्टडी करी थी तब 100 बच्चे के करीब आपने किए थे, अब वो 1000, 2, 1500, 1600 के करीब बच्चे हैं टोटल, जो टोटल पूल है एविडेंस का, और उसके अंदर डिक्रीज इंसिडेंस ऑफ एयरलिक्स आ गया है। आई एम नॉट टेलिंग दिस। अब वीडियो बेस्ड ट्रेनिंग वर्सेस रैंडमाइज इंस्ट्रक्टर बेस्ड ट्रेनिंग, जो लोग वीडियो बेस्ड भी कर रहे हैं, और आज ऑगमेंटेड विजुअल क्या कहते हैं AVR जो गॉगल्स लगाते हैं, उस गॉगल के साथ भी आप रियलिटी में आप रोज बैठ के अपने कर सकते हैं अस्पताल के अंदर, whether that has caused, so it was found that to be fine. So with this I finish here, and I urge you all to please join for our NRP workshop. NNF is already doing a NEOSHINE program where हम सारे फर्स्ट ईयर MD स्टूडेंट्स, अभी सिर्फ MD कर रहा है, DNB नहीं कर रहे, MD स्टूडेंट्स को 12 वीक का कोर्स कर रहे हैं, एंड देन वी आर गोइंग ऑन विद कमिंग अप विद ventilation work course and eco course, but that will be only done for those who have done NRP and NEOSHINE. जिन्होंने NRP और NEOSHINE करा होगा, उनको ही हम ventilation course और eco course के लिए enroll करेंगे. Thank you.
Thank you, Dr. Surender, and it was a very, very enlightening and very extensively covering the topic of resuscitation. I understand that it's very difficult to cover everything, but first I like to have comments from Dr. Sanjeev Kumar, and then we can take questions and answers. Dr. Sanjeev Kumar.
Thank you, Dr. BISHT. A very useful and practically important talk.
Let me just stop here. Yeah.
I hope all the students and practicing pediatricians are benefited. Reviving the baby safely is very rewarding. So thank you very much for a very nice. Thank you very much.
So, Dr. BISHT, there are a lot of questions which I like to take one by one, but before that, just one common question in mind, or it comes to our mind also, that if a person who is already a trained pediatrician, like he has done in his MD, DCH, but because of some reason he has not done an NRP program, the certification course, and he attends a delivery and that leads into some complications, and then he goes to court, the patient goes to court and says that this person is not NRP trained. And so what is the legal implication of a MD pediatrician or a DCH pediatrician who has not attended NRP course in the court of law?
So, Dr. Pankaj, as of now, NRP is a part of NMC curriculum in the for DCH and MD course. So it is assumed the one who has passed MD and DCH has got the training, because that is something which we have a station in our final MD or DNB or DCH exam also. So it is assumed that they have done it, and there is no not a mandatory that NRP needs to be done as such. But with NABH coming and doing accreditation and other accreditation also going on along with that, so there is a mandatory criteria out of that the staff needs to be NRP trained. In that scenario, a hospital which claims to have got that kind of accreditation is supposed to hire all people who are either NRP trained, or they should organize such training in their hospital. If that is not done, that is assumed that you got that accreditation with that way and you are not following the norms, and you are in that scenario, you are telling the client, the customer or the patient the wrong thing, because they are supposed to be, they are coming to a hospital which is accredited and should have had all providers being trained in NRP by the way they have said, because they are asking for a certificate. So in that scenario, their validity is that. But as such, in all other hospitals, government hospitals and other like this, anybody who is MD and DCH is good enough to successful.
So I think currently we have this NRP is part of your MD DCH courses, but those pediatricians who have done their MD DCH previously, so at that time it was not part of the curriculum.
So this is the being a devil's advocate. So now the time has come that our patients are getting more smarter. They are being kind of given this information by one of us also. And yes, the teachers, the people should know how to do it. And time is not far, then people can have a detail. When you look at the NEO reviews, you read NEO reviews, and there is a section when verbatim what is happening in a labor room is mentioned there, and there is a court case going on, and that the nurse actually narrates everything in the court in her records, and that is the time when it may come, and people need to find who was responsible for the baby actually ending up CP.
So right now there is not a mandate, but I think time will come and this will also become a mandate. So it's a responsibility.
Time has come, sir. We are getting, in fact, NNF got some queries from here and there about some hospitals, whether their people were trained or not trained. You are right.
So we should try to tighten our girdles.
Yes, yesterday I got a RTI also.
Yeah. So I think it's a good opportunity for all of the pediatricians who are attending this, that NRP by talk is just a sensitization. Ultimately, it has to be a one-day course, and all of you should attend that course. That is just to start the beginning. So now I come to questions. There's a question which says that why injection epinephrine is used last in NRP steps? What will happen if it is used before? That is BISHT.
So good. This is a conceptual question. In fact, I'm really thankful to people who are asking this, because हम क्वेश्चन पूछना छोड़ देते हैं, हम सोचते हैं कि ये तो क्या कहेंगे, कि ये तो कैसे बोल सकते हैं, ये तो लिखा हुआ है, ये तो ऐसे ही होना चाहिए. नहीं, ऐसा नहीं है, तो लोगों को पूछना चाहिए. So sir, madam, I don't know who is there. So
then it's anonymous attendance, so we can't.
Anonymous, अच्छा, ठीक है. So good is there. आपको हमें आइडिया क्या है एपिनेफ्रिन से करने वाले क्या है? हम एपिनेफ्रिन से आइनोट्रोपिक काम करेगा, क्रोनोट्रोपिक काम करेगा, ड्रोपोट्रोपिक काम करेगा. बच्चों में हार्ट रेट इज नॉट अ प्रॉब्लम, इट्स अ वेंटिलेशन विच इज अ मेजर प्रॉब्लम. Establishing appropriate ventilation is the reason for causing bradycardia. It is not the rhythm disorder in other situations which will cause it. It is not the heart which is failing otherwise also. It is the ventilation which is a problem. So for newborn resuscitation, we are not doing chest compression first, unlike in adult resuscitation. in pediatric in neonatal resuscitation, certainly, if not in the bigger children resuscitation, we believe that there's evidence to say that it is ventilation which needs to be improved before this. So you do all corrective steps, and then you have chest compression, and many a time, because of chest compression, the return of spontaneous circulation, ROSC, which is we have done in all animal studies. So हम ये lamb पे करते हैं, बच्चों पे करते हैं. I'm fortunate that I went to New York Einstein College of Medicine and saw some animal studies being done. जब आप animal को sacrifice करते हैं या फिर carotid block करते हैं, and then you are trying to induce asphyxia, and then you are doing all those things. So, and then you are looking at the effects of asphyxia on those animals. So I was fortunate to have seen that, and this is the kind of evidence which has come. So there is evidence that you establish ventilation first, and having done an establishment by putting an alternative airway by putting a tube and then inflating the lung, recruiting lung, and then still if the heart is not pumping because of prolonged acidosis, you need to correct you take over the work and try to provide it to the lung to get it oxygenation of the blood and to vital organs to start respiration. And once done that, it will improve. And even after 60 seconds of chest compression, if the heart rate doesn't improve, that is the time probably this minuscule babies, number of babies would be benefited by epinephrine, which is comes to around less than 0.1 to 1% only. Very difficult to save this baby. Dr. Pankaj, I'm heard.
It is through hardcore evidence that these guidelines have come. So through animal studies, so we have to respect them, and asking question is always a good idea. So Dr. Bisht, we are in an era when counseling is a very important part of the overall treatment program. So if how to counsel parents, can you give some practical tips stepwise for a patient who suffered asphyxia despite doing everything through NRP program? So some practical tips.
So again a very good question, Pankaj. तो हाँ, आप एनआरपी जानते हैं, इसका मतलब नहीं कि आप सारे बच्चे बचा लेंगे, और बच्चे हमारी वजह से नहीं बिगड़े हैं, कुछ कारण थे उनके, इतने सारे कारण है भाई. There's so many of causes which can lead to a depressed baby being born. So yes, we are there to help and support a baby coming out from that neonatal depression. So we are there, and for that we have to give a correct assessment to a family who has come with cord prolapse, imagine, or a baby being born with 25 weaker. That's a different, that is not with neural resuscitation, that there are so many other things of counseling. But severe type 3, type 2 CTG tracing, or you can say late decelerations coming, or fetal heart rate not coming, thick meconium strain liquor. You need to tell families that the baby would require help and support at birth. And we are there, we are trained in that. We will provide all the help possible with the baby, and we will walk together.
That means that documentation will be very important there also, because I know this era when counseling is very, very important, and we can't save all babies. That's not possible. But then to save yourself, at least to save yourself for the medical legal issues which are coming up. And as I'm told that the resuscitation and perineal asphyxia is the biggest area where medical legal suits are filed against doctors and obstetricians and neonatologists, pediatricians, because people feel that asphyxia is 100% preventable, which is not.
Dr. Pankaj, अब जो OTT से सारे सीरियल पहले बाहर आते थे, अब वो इंडिया में भी दिख रहे हैं, और वो उनकी वो हिंदी लैंग्वेज में भी आ जाते हैं, तो हमारे वकील भी अब सीखने लग गए हैं सर.
Yeah, absolutely. So the next question is, Dr. Vino is asking, is it okay to stimulate before clearing secretions? Very obvious, but then your answer to this.
Pardon?
Is it okay to stimulate the baby before clearing secretions?
So yeah, बहुत strong evidence नहीं है. ये हमारा expert opinion था कि अगर हमने stimulate कर दिया तो बच्चा aspirate कर जाएगा, whatever this. So this is what we were. हम इसी तरह से पले बड़े हैं, इसी बात से हम पले बड़े हैं, मगर इसका कोई स्ट्रॉन्ग एविडेंस नहीं. ठीक है, नहीं है. तो जब हम ड्राइंग कर रहे हैं, जब हम बच्चे को लेकर, सबसे पहले हमने कह रहे हैं हमारे लिए अब सबसे बड़ा इंपॉर्टेंट चीज हो गई है कि बच्चे का टेम्परेचर मेंटेन कर लीजिए आप. क्योंकि वो 1 डिग्री जो ठंडा हो जाता है बच्चा, उससे 28% ज्यादा मोर्टेलिटी हो सकती है। तो वो 1 डिग्री की इंपॉर्टेंट, तो हमें ड्राइंग सबसे पहले कर रहे हैं। जब हम ड्राइंग कर ही रहे हैं तो एक तरह से हमारा स्टिमुलेशन हो जाता है। पहले हम ड्राइंग भी नहीं करते थे, लॉन्ग टाइम बैक जब हम पढ़ रहे थे, हम सबसे पहले गीला बच्चा रख देते थे, उससे पहले उसको पोजीशन करते थे, सक्शन करते थे, फिर ड्राइंग रिमूविंग मटेरियल एंड देन वी आर डूइंग स्टिमुलेशन। दिस इज हाउ वी आर डूइंग इट। तो अब वो नहीं कर रहे हैं ना हम, तो अब दिस इज हाउ इट गोज, वी आर बिकमिंग मोर प्रैक्टिकल। जैसा होता है, जैसा हो सकता है, एक नर्स लेती है बच्चे को और जब वो पूछती है तो पोछ ही रही है आगे पीछे, तो बैक पे भी 2 रब कर देते हैं। दिस हाउ वी गो। बट हमारे स्टिल आईपी एनएनएफ स्टिल हमारे एक्सपर्ट्स ने अभी भी आपका जो कह रहे हैं वैसे ही करा है कि नहीं, पहले आप सिक्रेशन रिमूव कीजिए फिर स्टिमुलेशन कीजिए।
So,
but there is no evidence, correct evidence.
there is no evidence, but that's whatever is the recommendation right now is to clear.
हमने आईपी ने दिया है, बट अमेरिकन एकेडमी ने प्रैक्टिकल मान ली है और उस पे लिखा है एक लेवल ऑफ एविडेंस, इट इज बेस्ड नॉट ऑन एनी साइंटिफिक एविडेंस, बट ऑन प्रैक्टिकल थिंग्स, एक्सपीरियंस.
So another question by Dr. Arshad is, what should be the dimensions of shoulder roll which you place under the shoulder? Any specific?
तो 2015 वाले में शोल्डर रोल हटा दे या करे ना करे, बिकॉज आप कुछ भी चीज मैंडेटरी कर देते हैं तो दैट बिकम्स अ प्रॉब्लम. नहीं, वो होना ही चाहिए. अब वो आपके पास जब आपने क्वालिटी की स्टडीज करी,
we have again lost connection. I think what Dr. Bisht is trying to say that we just place a roll to
you don't have blood. हर बच्चे के साथ चेंज करना पड़ेगा. तो शोल्डर रोल हमने जो पहले पढ़ाते थे, अभी तक की कोई क्लियर कट नहीं है. इट शुड नॉट बी टू बिग, इट शुड नॉट बी टू लेस, इट शुड नॉट कॉज ओवर एक्सटेंशन, इट नॉट कॉज अंडर फ्लेक्शन ऑफ द हेड, एंड इट शुड नॉट बी प्लेस्ड below the this. I think another 5 minutes, Pankaj.
Right. We'll wind it up fast. Dr. S.C. Karath and Dr. Yasmin have requested to speak in English. I will continue that in next session. Maybe for this time we just mixed up the two things, but yes, we'll take care of that.
I tried not to speak in Hindi.
Right.
Only 5-10% only.
Right. So what flow of 100% oxygen we should keep? 10 liters?
So if you are using a self-inflating bag, in that we don't use oxygen at all during resuscitation right now, because most of the time when you are using PPV, room air is what is required. So, and for preterm babies you would require 21 to 30%. For inflating, for a TP resuscitator you would require 10 liters or something which is actually the flow which is generating some pressure. So you would require 10 liter also.
So for recommendation,
for a bag
10
also,
liters.
The American Academy says 10 liter. We were using 5 liter per minute. So we have taken 5 to 10 liter.
Right. So start CPAP in labor room by the use of TPs. That's very obvious. What about cord milking? Any comment?
Cord milking, the Zuri till now is not to give for, certainly not for preterm babies, less than 28 weeks. But yes, for others, milking can be done, but no strong recommendation has been given by IAP. Those who can do it, can do it. Because Anup Kataria did say it is workable, it is doable.
So if I remember correctly, Dr. Bisht, if it is more than 29 weeks and baby requires resuscitation, so the cord milking is okay, but less than 29 weeks, it has harmful effects.
It is harmful. It's harmful. It's not to be given.
Right. So Dr. Anupama and Dr. Anupama Sharma had asked that question. There's Dr. A.K. Sharma asking how to do 2 thumbs chest compression if it is a single rescuer.
So, sir,
can be done.
Sir, single rescuer से बच्चे नहीं बचने वाले इतनी हालत में जाके. So आपको single rescuer, अब important है कि आप ऐसे कोई जगह नहीं है जहाँ बच्चा पैदा होता है आप अकेले होते हैं. एक नर्स होती है, एक आया होती है, एक टेक्नीशियन हो सकता है, एक ओटी में ओटी बॉय हो सकता है. You need not have 3 pediatrician, 2 pediatrician. There needs to be एक resident doctor, RMO हो सकता है. तो कोई भी हो सकता है जो हो सकता है. तो single rescuer कि आप ही के पास आके सडनली आपके क्लिनिक में बच्चा पैदा हो जाए, दैट इज आई डोंट नो, दैट इज इफ यू आर मी टू से. बट इसके अलावा अगर वो लेबर रूम में है, देयर आर मेनी पीपल, सिंगल रेस्क्यूअर का कोई स्कीम ही नहीं है.
I think he has to leave one thing to do another thing, that's for sure, right? Whether 2 thumbs or 2 fingers does not matter.
There is a gynecologist who is available there.
So any comment on head cooling versus whole body cooling, which is recommended today?
This is beyond the scope of this.
Right. So whole body cooling,
I didn't go for that, but certainly and with the NNF का हमारा कुछ stand है उसके अंदर, हमने पूरा
I think what I can say is whole body
position statement
cooling is the
निकाल
only
रखा है.
cooling.
Therapeutic
Yeah.
hypothermia should be provided for institutions जिसको हमने list कर रखा है. Only अगर आपके पास ये सुविधाएं हैं, ये expertise है, बच्चे की एक precondition, the newborn is presenting with these preconditions, with coming within this hour, this is the pH, this is something. If these preconditions are followed, you have that kind of a manpower, then probably you should do it.
So we are doing cooling, but
whole body cooling.
Nobody is doing head cooling now. Everybody is doing
No.
whole
That is
body
ice cool cap is gone. Ice cap is gone. It's
Yeah,
all
that
the
is-
whole.
Yeah.
That's
So
gone.
now everybody is doing whole body cooling.
So not everybody should not do. Not everybody should not do. We have a statement on that. It should be done only
Right.
by people who can do it in places where it can be done, and to the babies who are the best candidates.
Okay. So Dr. Ananthan is asking which is the NRP text you added. I think
Pardon?
this is NRP text. I think this is from the NRP NNF IEP book.
So
Right?
IIP NNF textbook of neutral resuscitation
Right.
by Dr. Piyush Gupta and Dr.
So if you
Siddharth
can
Ji.
share that in the delegate group or you can share in the faculty group, you can share in the, if it is okay with you.
No soft copies available. You can get it from Amazon.
Okay, fine. You can get it from Amazon. Dr. Meena Khilani is asking if a baby is delivered with no respiratory effort, no heart rate. Do we still start with resuscitative measures?
Okay, that's a very important question. In fact, thank you for asking this. So what I tell my residents, you are not going to label anybody stillbirth, even if your obstetrician gynecologist is crying hoarse about it all. If it is a fresh stillbirth, not macerated, I'm not trusting their ultrasound. I'm not trusting their FHS. I'm not trusting anything. Legally, we are not supposed to trust that out. For anything, a baby born, you are not going to measure the heart rate to note the heart rate immediately. You go through the algorithm. And only after 20 minutes, you will be able, going through everything. For a baby, when you say there's no heart rate, no respiration, it will be only after 20 minutes. Then only you can say it is a fresh stillbirth. You need not make an admission of that patient. But yes, you have to note that you did everything possible. You did chest compression, you did intubation, you did put an UVC line, you did adrenaline. And only after 20 minutes, then you are medically legally safe to call that baby fresh stillbirth. No obstetrician is going to save you if they are saying कि बच्चे में कुछ नहीं है, आप मत कीजिए resuscitation. नहीं हो सकता है. In my hospital, every stillbirth, and that is true for everybody. Should be for everybody, because every stillbirth which an obstetrician is claiming कि बच्चा FHS नहीं था, still आपको सब कुछ करना है until and unless baby is macerated. Only two contraindication is anencephaly or macerated stillbirth of doing neutral resuscitation. Third is still parents not ready for counseling and not ready for this, which we do not want, because we have seen max incidents. We will not let that. Only two contraindications for neutral resuscitation is if it is a macerated stillbirth or if there is anencephaly. Even for Edward, now we are not stopping it. For Downs, we are not doing it. Okay. Third is about parental consent, when parents have already said no, for this gross malformed baby, we do not want resuscitation. Still, we do it. But only for this condition. For somebody saying no heart rate, no respiration, I don't believe this. You do it for 20 minutes, then we will say only.
And we have seen babies getting out of this state.
That is the reason what NRP, American Academy says. Even earlier it was 10 minutes. 2010, it became 10 minutes of active resuscitation. Then it was found, even after 10 minutes of active resuscitation, when there was no heart rate, no respiration, babies came out well. Not well, but they survived.
Right. So coming to the next question by Dr. Smita Malviya, NRP certificate is valid for how many years? 2 years. 2 years. 2 years. Right. So does delayed cord clamping leads to polycythemia? I think the lecture does not have it on delayed cord clamping.
I said there's not effect. Not much effect with jaundice, mild jaundice.
Right. Asymptomatic polycythemia increases, not symptomatic, not a problem.
Not a problem.
Dr. Virender, we will definitely be sharing the presentation, not the PPT, but we'll be sharing the session which Dr. BISHT has taken into this group. So you can use that session for
Now I have to rush. I am coming to your place now. Rushing to your place now. I have to drive to RML from Noida.
I'm also on way. How many maximally can we give adrenaline doses? How many doses?
How many doses? So you have to do it for 20 minutes. So assuming that by 2 or 3 minutes you have started, you are giving your first dose, and after 3 to 5 minutes, you may need to give 3 or 4 doses.
Right. Maximum dose of epinephrine?
Maximum dose of epinephrine.
Maximum. One single dose maximum.
That is based on weight only, 0.2 ml per kg.
Right.
0.3 ml per kg.
So you can give through endotracheal tube also, not a problem, but dose increases. Milking is not recommended.
Endotracheal tube dose is hardly counted as an effective dose only. That is a zero dose. That is not counted for the number of doses.
Right. So you can give 1 cc per kg if you really want to do a ET and you don't have an IV access, but we don't recommend.
But that is not counted. That will not be counted as epinephrine dose. You have to give an IV epinephrine dose after that.
Transportation is not the scope of today's presentation, Dr. Yasmin. Transportation will be some other time. So also resuscitation is already claimed in IUD babies. Needed, I think that has been discussed. Even if it is IUD, till the time maceration happens, you need to do resuscitation.
You can only say IUD after 20 minutes.
Yeah, so you declared it after 20 minutes. Absolutely. Dr. Rajkumar Paul wants to ask medical legal implication, which we discussed already, but that is very important question of not having cooling devices. I think that is another aspect added. If you don't have
refer to NNF position statement. Please download it. Please download it. Keep it, read it, and have a summary of that there. That is fine for you. You need not everybody needs to have a cooling device.
Right. Dr. Hamad wants to ask RS negative pregnancy.
That's a different topic.
And delayed code camping recommended, no problem. Yeah, but in any case, it is recommended. Not you
are
not
recommended. No, that's not an contraindication.
So sometime Dr. Rajni wants to ask a baby whose penile asphyxia has profuse secretions time to time. Repeated suctioning has to be done. Does that increase the chance of bleeding?
That's a different thing only. Right. But I don't think we haven't said so. But asphyxia babies later on, when they are having stage 1 of HIE, parasympathetic stimulation, they will have copious of secretions. That becomes a problem. We need to intubate that patient, sometimes ventilate that patient. That's a different story.
So there is no role of atropine in today's era?
No.
Atropine, no role?
Big no. No.
Right. So I think rest of the questions are addressed to us, like me and my team. So we will be sharing this, and the last session is also being shared with the delegates, so you can attend that session also. And after completing all these 15 sessions, only those who have attended these sessions.
Can I leave, Pankaj?
Yeah. Thank you so much.
Thank you, Dr. Pankaj, Dr. Bhandari, Dr. Ajay, Dr. Sanjeev, and all of you who are there. And please attend the NRP training provider.
Thank you, Dr. Bisht. So all of you who have attended these sessions. Yeah, I understand, Dr. Bisht, you have, right. So for all of, so over to you, Dr. Sanjeev, and Dr. Sanjeev, any last words from you?
No. Very nicely explained. All the queries were cleared. Very nice presentation. Very useful. Thank you very much.
So with this, we end today's session. We hope that we have answered all your questions, and if you have not, you can still ask questions in the delegate group, and I will request Dr. Bisht, and I'll try to do it myself also to answer those questions. And you have to attend all the sessions live, because we have attendance of all the sessions. If you attended all the sessions, then at the end of it, we will be providing a certificate there that you have attended all these 15 sessions on all these topics by all these speakers. So with these words, thank you so much. Jai Hind, Jai IIP, keep on learning things. We are here to help newborns survive better in this world. And also, last but not the least, Happy Mother's Day to all those mothers who are giving us responsibility to take care of their newborns. Thank you so much.